We're going to focus the talk on the surgical anatomy of C1 and C2. And this formidable anatomy to learn is compact, as you all know, is in a small little area, but is surrounded by a lot of high-priced real estate. So you have to know all of the nuances, surgical, etc., in order to make sure that that spinal region is stable, functioning appropriately, so that you don't irritate or cause disharmony with some of the neural structures that are here nearby. Some situations are beyond our control, but a good working knowledge of the basics of the human anatomy that you can see with the naked eye in this region serves people well. So a one-slide embryology distilled from all of the weeks and weeks of development of the spine you can find here. So around the third week of gestation, we enter into gastrulations. We develop this three-layered little creature, and it's composed of endoderm, mesoderm, and ectoderm. And it's that mesoderm that we want to focus on, because if you look, that mesoderm then proliferates and turns into paraxial mesoderm, which that's the key term we're going to focus on when we talk about the spine. There's lateral plate mesoderm, and then we also have some intermediate mesoderm. Lateral plate mesoderm, as you remember, basically gives rise to your circulatory system and the limbs, in essence. Intermediate mesoderm gives rise to the urogenital system, and then paraxial mesoderm that we're left with gives rise to the axial skeleton. So that's our focus. Around the end of the first month, we'll see that paraxial mesoderm starts to form these small little clusters of cells that aren't very defined. These are some metameres. And then that eventually becomes your somites, right? We have 42 somites, or blocks of mesoderm, 4 occipital. And then kind of the essence take-home from this slide is that each of those somites will then differentiate into scleroderm, right, which is bone and ligament, dermatome, skin, and myotome, which is the muscles. All right, so that being said, a little group of cells that differentiate from that mesoderm structure form your notochord. And you all know from probably high school these days that the notochord induces the overlying ectoderm to turn into neuroectoderm, and our neurotube is formed. It also does other things. It forms a stability factor for us that are in the phylum Chordata, right? So that we're not a jellyfish dependent on the water to keep us buoyant. We have a rod that helps keep us nice and straight and helps in stability. And this shows you a little section through a fetus. That black line that climbs up through the sagittal section is the notochord, and we see it ascends up through the odontoid. It crosses that little gulf between the odontoid and the basion, and then ascends on up into the sphenoid. And these are sites that you can find chordomas, right, where you have continued rest of these notochordal cells. This is a great slide, and if you can get this slide in your head, you basically understand all of the embryology that goes into the cranial-cervical junction. And if we look to the far left, we see the sclerotomes and a notochord tube that's basically being formed there in the middle. After some resegmentation, those sclerotomes form these building blocks. And we have the upper group of blocks, or somites. The first 3 are the occipital somites. And then the key to the entire cranial-cervical junction is the proatlas, which is in essence just another name for the 4th occipital somite. Then we see the upper 3 cervical somites. You'll notice still you see the notochord shadowed in there, kind of splitting those blocks into a front and back part. So we have a hypocordial portion in the front that you can see for C2 and C3 basically disappears. The rest of the spine disappears. Whereas for C1 and the proatlas, it stays and actually contributes to some of that adult morphology that we're going to see. So now, very easy, you just track over and see the adult form, and you'll see that the C1 block of mesoderm there forms most of C2, posterior elements of C2. The bottom of C2 is formed from the C2 block. And then you see a little of the remnants of the proatlas in there in red. So the apex of the odontoid, some of the skull base, including the basion. If you have a 3rd occipital condyle, that's said to be derived from proatlas. Some folks think that the transverse ligament is derived from the proatlas as well. All right, if we move forward a little bit, we'll see that essentially if you look at C1 and its ossification centers, the one on the left is what most findings will represent. So we have 3 blocks, right? 2 lateral groups and then an anterior group. And the one I show you on the right is a CT image that shows you that sometimes you can have variation. So for example, in this one, the anterior groups have 2 ossification centers. That moves forward and gives you something that looks like that, this little, and this is blown up probably 3 times. But this very small area, the atlas, which is so essential for normal movement and function of this region. So if you look at the atlas, you see that the superior aspect has these superior articular facets. This one in particular has a little variation in that the facets are bilobed. Sometimes they can be completely bipartite, so that there's 2 separate facets on either side. You can also see that just here we see a little tubercle here and here. Those are the tubercles, or the atlantal tubercles, for attachment for your transverse ligament. So that little section there, that little 1/5 of this entire ring-shaped area is for the odontoid process to project up into. You can also see, if you look out laterally, the transverse foramina. We only see these in the cervical spine, but you remember that it's only the upper 6 cervical transverse foramina that the vertebral artery normally travels through. So the C7 is just for the vertebral vein or venous plexus. This has a variant on the right side or left side where we see a retrocondylar foramen, and that's usually said to be for a little vein. And sometimes you'll see that if you're manipulating the vertebral artery out of its vertebral artery groove, which is here. And I'll show you in a better picture. If you look at a cross-section through the atlas, this is actually a great picture to kind of fuse in your hippocampus somewhere, because this shows you exactly what type of bone you're going through when you're putting in a screw into C1. So you can see, looking from the underside, you basically want to aim between that atlantal tubercle and then that transverse foramen. And there's lots of different ways that have been suggested on how to do that. But in essence, those are the 2 things you're trying to avoid. You don't want to interrupt the transverse ligament, and you don't want to get into the foramen. This is I'll also show you that. So when you look at this from the underside, and most people don't, you see what, when we have taught other courses, the skull there. So that area in the middle of C1 looks just like, you know, how you draw in grade school, the skull, and gives you a good idea of what the canal portion of the C1 is versus the portion that's built just to house the odontoid. This is a nice posterior view. So the arrow up in front shows you the facet for articulation with the anterior facet of the odontoid. The right arrow shows you the vertebral artery groove. And then on the left, a piece of red tubing that represents the vertebral artery. You'll note on the left side that retrocondylar area is a little protuberant and is pushing down on the artery a little bit. So if you're trying to liberate the artery during various procedures, if you're trying to put a C1 screw in, for example, and you're peeking underneath the vert, sometimes it can get stuck in that retrocondylar place. And I'll show you another image shortly that actually that retrocondylar bone can fuse on down to the posterior arch and form a complete foramen, an arcuate foramen, which can confuse the surgeon during procedures back there. There's an interesting view, 3D CT reconstruction, that shows a defect in the posterior arch of C1. Here we see the posterior arch, anterior arch. Remember, there's never the ability to do a laminectomy on someone's C1, although you hear that mentioned all the time in operative notes. So there is no lamina of C1. There's just the posterior and anterior arches. Here we see the facets, and you look at the essence, and there's a variety, but about 30 by 35 millimeters is normal dimensions of the inside of that C1 ring. Here's the underside, shows you some of those same points. Also point out that the anterior arch has this anterior tubercle on it, and the thing that attaches to that you'll see potentially when you're doing a way up high approach to the anterior craniocervical junction is that's the last point of attachment for the longest cervices. So longus cervicis ends and creates that anterior tubercle of C1. The posterior tubercle of C1 that you see there is created by a single muscle, which is the rectus capitis posterior minor. So the next few slides are going to show you some variants in the C1 region. So here's that retrocondylar region that's almost about to form this arcuate foramen. Here we see the arcuate foramen on the right side there at the arrow from an oblique view. And then you can see an arcuate foramen with vert traveling through it on the left, and that CTA. You can also have the body try to bridge the gap between C1 and the occiput with these various compilations. So we can have a paramastoid process that protrudes inferiorly and tries to articulate with the C1. You can have an epitransverse process that protrudes up from C1's transverse process and tries to do the same thing. These can form pseudo joints. They can be a fused piece of bone and inhibit motion. This is a good dry skull example of Atlanto-occipital fusion, and it shows you that in Atlanto-occipital fusion, very often the posterior arch is bifid, just like you see here. The other thing is, if you look, almost all of these cases, the verts, as they enter into the skull, have to take an anomalous course. So they don't take the normal course because it's covered over with bone. So anyone with AO fusion, you have to be careful that the verts, that you know exactly where they are. So C2, just briefly, some of the very basic morphology. We see the essence of the embryological components of C2. We have the two lateral neural components. We have an apical part. The odontoid is actually two separate parts, left to right, and then we have the body. And now, the confusion with all the terminology, and I've just put a peppering of some of these terms that you can find in the literature, and why it makes it so confusing when people are talking about C2 is we give the same name, or we give different names for the same structure. So apex or tip, some people talk about a waist, a neck, a stem, a base, and they really mean the same thing, more or less. A shoulder, a base from the front, a base from the side. We have odontoid process, dens, peg, shaft, all those are used interchangeably. The actual formal name in the anatomy, Bible is dens, right? Odontoid is not even a term that's recognized. The odontoid has its own trabecular pattern, as you can see there on the right. That's a complicated cicatrix of bony webs. If you can, and you can find these even in adults, you can see remnants of the fusion sites of ossification between the parts of the den. So we have variously named apical dental and chondrum terminale junction there at the top that fuses your apex down to the rest of the dens. And then we have the subdental synchondrosis that has various different terminologies. And that you can actually really see in a large proportion of adult patients if you look for it. This is a reconstructed image, and you can see at the arrow, there's the subdental synchondrosis. It's a nice little illustration of it. Here's the underside view of the dens that you don't see very often, and you can see that it has a little foramen here that is often not appreciated, but that's just the basivertebral foramen for the basivertebral vein that enters C2. Just like all the other vertebra, you have one here as well. Measurements, there's a lot there to distill, but essentially, if you look at a wide range, the dens is about 15 by 11 millimeters. If you look at its foramen at C2, it's roughly 20 by 23. Now, confusion, especially in the surgical world, when you start talking about the difference between what is the pars interarticularis of C2 versus the pedicle of C2, and you can try to digest that picture and see the difference. But essentially, what most people call a pedicle screw is in essence initially a pars screw, right? It starts off in pars interarticularis. In this image, which we cut here, you can see the upper arrow on the lower left image is the pedicle, and then the lower arrow, what do you think is causing that? What is that indentation from? Vert. So that's the vertebral artery that's pushing there just under the pedicle. The upper image is canted just a little bit, so you get a very nice view of an entrance side into the pars, and then you also see the very thin pedicle. Yes?
So this is one of these age-old back and forth, right? What do you call that screw?
Yeah.
And how do you discern the difference between a C2 lateral mass screw, a C2 pars screw, and a C2 pedicle screw?
Right.
So in your mind, what is the appropriate use of those terms?
Yeah, it's subjective. So if you look in the formal book of anatomy terminology, which is called Terminology Anatomica, it doesn't even list those two. So it doesn't describe them, and probably it's just turning its head because it knows there's controversy. I think if you look at where the screw first enters, that's definitely the part that we call pars everywhere else. It's between the superior and inferior articular facets.
Yeah.
And then as you go more deeply into what that upper arrow shows, then you're into what a pedicle of C2 is, which you don't see unless you shave off the superior articular facet. So if you look at the dry bone, you really can't see the pedicle of C2.
And I'm assuming there's a upper cervical lab this afternoon. Yeah, so people can play through these things. I find C2 to be very forgiving because you can choose so many different ways to anchor a fixation point at C2. And then half the time I don't even know what to call what it is that I've just done. I just know that I've successfully deployed a screw into bone in a way that's going to allow me to achieve the task at hand.
That's where the truth lies, right? The terminology is probably a little superfluous, you know. So this is a last view that shows you a screw placed, whether you call it, you know, pedicle screw, etc. But the take-home message is the proximity of that screw. After I've taken off the superior articular facet there, you see exactly where the vert is and how close that is to impinging. There's a basivertebral foramen. Let's move on. A nice coronal section. So I showed you where the vert was in relationship to that pedicle. This shows you nicely on this image that the verts aren't really pushing and embedding in themselves into the body of C2, but you can have variants such as this one where the vert really burrows into the bone and can cause problems. We've classified that based on how much it burrows underneath that pedicle and into the side of the body. So let's, in lieu of time, so odontoid can be retroverted. This shows you a nice image where odontoid is not vertically oriented. It's pushed back a little bit. And we've looked at that in the past and shown that as long as it doesn't impinge on the anterior or efface the anterior dura more than about 9 millimeters, then that's usually okay and tolerated. Some variants in this area, what would that be? Ossiculum terminale, right? And some of the older literature calls it a Bergman's tubercle. How about that? An os, right? Odontoidium. How about the one on the left there? Cornudenus, right? Just means a bifid or split dens tip.
Okay, Shade. So here's another controversy.
Yeah.
What is the etiology of os odontoidium?
Yeah, I've actually looked at that recently, and you know, some that will say it's all traumatic and that you lose the blood supply and this little osseous island goes out and lives its life independently of the odontoid. Some say that it's a congenital issue, it's not traumatic, and that there's a secondary trauma to that upper apical synchondrosis, and that's what causes it. So the jury's still out there. There's not a definitive, other than anecdotal literature to show that. And it's probably both, yeah. Yeah. Thank you, Charlie.
Do you think that it requires trauma before a certain age?
You know, I come from a pediatric neurosurgical group where I've worked, 25 years, and you just don't see that. There's no history when you find these that there was some early trauma. Yeah. What about the one on the right there? Any guesses? Clipophile, right? All right, let's throw some ligaments on these little bones and help hold them together and keep us from being paralyzed. So there's that transverse ligament that I mentioned to you that anchors to the left and right atlantal tubercles. What's unusual about that as being a ligament? So most ligaments should cross bone and go to another bone, right? They shouldn't stay on the same bone. So that's one oddity where the transverse ligament stays on the same bone. It's not holding that bone together or another bone to it. It's helping keep the odontoid in place. Now, the transverse, as you know, is just part of that larger constellation, the cruciate ligament. So we see the vertical bands of that. And if you peel back that vertical ligament on the top, you get a hint of the apical ligament that's coming off the apex of the dens. And then between that, you see the alar ligaments. These come off laterally and attach just medial to what structure? Occipital condyles, right? So you can disrupt these with condylar fractures is an important take-home message. And then finally, you see that to get to that area, which this is not compatible with life, you have to undo the tectorial membrane, which is just a continuation cephalad of the posterior longitudinal ligament. Capsular ligaments that we see here on the left between the AO and the AA joint, and then a nice view of the alar ligaments, which limit rotation, axial rotation. Apical ligament I've looked at in the past, and it's often not even there. It gives no stability. It's a little wisp of tissue, so it's most likely some degenerated part of the notochord. Some ephemeral ligaments. This is the lateral atlanto-occipital ligament that's just deep to the muscle I've turned down here. That's the rectus capitis lateralis. You can also find a transverse occipital ligament that we've reported on. This is a little aberrant connection that runs kind of foramen one side to foramen the other side and is just at the apex of the odontoid. Barkow's ligament here has a funny construction in that it runs kind of condyle to condyle, but just in front of the tip of the odontoid process, and probably serves as just an extra supportive layer to keep it from the odontoid from going forward. We see the lateral atlanto-occipital ligament that I showed you. This also shows you the midline anterior longitudinal ligament, and then as that ascends up to the skull base, it changes its name to anterior atlanto-axial, and then the same structure, anterior atlanto-occipital ligament. We mentioned this little ligament a couple years ago, the anterior atlanto-dental ligament, that hard to get to and has been mentioned maybe twice in the literature. Now, if you look at kind of a take-home slide, look at some of the tensile strength. So a lot of those are small ligaments that alone do not contribute very much. Looking here, we see transverse ligament is the winner. That's the important one to function or to focus on. Capsular ligaments, which is not intuitive, is a second runner-up at 300. Then alar tectorial membrane. Let's go through some of the various muscles that we see with the approach, and also following the next talk, we'll have a lab demo that we put together for you that basically goes through this. So I'm going to scurry through these for time purposes, but the first layer has already been taken down for you with this posterior approach. And I know during surgical approaches here and the Bovie, we stay in the midline and shave everything over, and we really lose a good appreciation of what these muscles are. But some of the relationships that they have, for example, with the greater occipital nerve, occipital artery, makes them important for at least remembering from time to time. So this is the splenius capitis that runs kind of oblique from mastoid and superior nuchal line medially and has that attachment onto the nuchal ligament. And you see peeking out just above that the greater occipital nerve as it pierces the semispinalis capitis. Here's semispinalis capitis, greater occipital nerve. You see a little hint of the third occipital nerve there down inferiorly. And then up at the top where the nuchal ligament ends is the inion. And then deep to the semispinalis capitis, we see our suboccipital triangle muscles. And again, we usually Bovie through these, making sure not to get in the vert, but they actually are great landmarks for identifying the contents within this little triangle, that being the vert, the suboccipital nerve, the posterior arch of the atlas, and the posterior atlanto-occipital membrane. An anterior view, again, we don't see this surgically, and if you do, you're way too lateral. But we see the longest capitis there labeled for you. Then inferior to that, we see the longest chole. ending at the anterior tubercle C1, as I mentioned to you before. The two arrows, these are muscles that you probably never see, but this is the rectus capitis lateralis and rectus capitis anterior, just helping to hold C1 to the base of the skull. Veins in this region, right? A formidable set of veins, and we often say, oh, paravertebral veins. They actually all have names. Some around the foramen extending right up to the hub of C1. This is the marginal sinus. We then see the various parts of the Batson's plexus, and one in particular you see here is the little basivertebral vein that enters into the back of C2. We also have our suboccipital venous plexus, contributed to by the vertebral venous plexus, and also the big vein that you'll often just grab your bipolar and take care of, which can be very large, is the deep cervical vein. And those will all come together, cross the midline usually. On the right there, we see the surrounding vertebral venous plexus, and is that a left vertebral artery or right vertebral artery? Right vertebral artery. So right vertebral artery, venous plexus, and you'll usually see the venous plexus before you get to the artery, so it's kind of a safety mechanism. And what do you think that vessel is coming off the horizontal segment of the vert there? It's a variation because you don't always see it, but that's pica, so that's the posterior inferior cerebellar artery with an extradural location. So vertebral artery deserves a few comments. So we see it at about the end of the first month and then into the second month of development. Comes from the dorsal aorta, which basically forms a lot of little insular connections that come together, coalesce, and form vertebral artery. This is a nice slide because you see what we think of as the normal vertebral artery, but it also shows you one of the fetal persistent vessels, that being a proatlantal artery, which in essence, if you look back a few steps in development, is what gives rise to the horizontal segment of the vertebral artery. So often if you have a persistent proatlantal type 1 or 2 artery, you'll see that the horizontal segment of the normal vert is missing or is small. How about some surgical relationships with the vertebral artery? So we see that in essence, it's kind of in safety's way in that the dentate ligaments have got its back, right? So vertebral artery is in front of the dentate ligaments. That protects you a little bit. The problem is what cranial nerve is behind the dentate? Accessory nerve. So you see the accessory nerve here, long course coming down from the upper 5 segments of the spinal cord, running behind that dentate. So in general, the vertebral artery, as far as left or right, it's easy to remember. Usually your right transverse sinus is bigger than the left, and it's usually the opposite for the vertebral artery. So often the left vertebral artery is a little bigger than the right. You can read through those later when you can't go to sleep and want to remember how many degrees of rotation before you kink the ipsilateral and kink the contralateral vertebral arteries, and that's a la Bohunder's syndrome. This very simple picture, but a take-home message is that from the midline till you get to the vert over laterally is not a long distance. And this picture shows a wide variation. That's not going to be much more than 2 centimeters. If you're more than 2 centimeters out from the midline, you're right on top of the vert if you're on the posterior arch of C1. Some branches people forget about that you see in the various parts of the vert. This is the right vert, as we see coming up with its segments. And we see that there's some branches to cord, radicular branches, ganglia that come off here from this SS segment. We see a big muscular branch that you can take that's called Salmon's artery. You see that there's a posterior meningeal that you can take usually. Pica, I just showed you a good example when you can see that. You can't take that if you have the choice. And sometimes you'll see a little branch to the joint, which you can obviously take. There's that same image. Now, there's a beautiful little arcade of arteries that come together and kind of drape over the odontoid, and you can see where these come from. For example, we have branches from the ascending pharyngeal artery. Where does the ascending pharyngeal artery come from? External carotid, right? So it's a weird terminal branch of the ascending pharyngeal that supplies this area. Where's the very terminal branch of the ascending pharyngeal artery? Where does it go? Jugular foramen, yeah. So posterior dura through the jugular foramen, good. So a la Grissel syndrome, where we have some maybe poor drainage or excess drainage of our retropharyngeal lymph nodes. This just shows you C1 and C2 drain into these nodes, and then these nodes go into the deep cervical chain, which lies along the internal jugular vein. All right, lastly, we'll throw in some nerves in the area. So this is our suboccipital triangle, and we see our oblique muscles, our capitis muscles. And the good thing about learning the inferior oblique is that it's a good landmark because just underneath it's where our greater occipital nerve comes out. Remember, that's the medial part of the C2 dorsal ramus. And then that's going to ascend up and pierce your semispinalis capitis. Sometimes it pierces trapezius. The nerve you don't have to worry about is the one that's there between C1 posterior arch and the vertebral artery, and that's the suboccipital nerve. It's the dorsal ramus of C1 and just innervates those little suboccipital triangle muscles plus minus semispinalis capitis. A nice relationship there of the C2 spinal nerve, and remember that relationship to the back of the articular complex when you're putting in your screws into C1. So arrows, left arrow, that's the greater occipital nerve, right? Remember, at that point, it's just sensory up to the vertex of the skull. The middle arrow is your third occipital nerve from C3, and then the clinically inconsequential suboccipital nerve from C1. Nearby and with the dura open, so in the lab we just open the dura. You can see the left arrow is the left vertebral artery that we've elevated to show you the C1 dorsal ramus, that suboccipital nerve. We then see at the asterisk, that's the second to highest dentate ligament, which is just an extension of pia mater that goes out and attaches to the inside. But it protects you from the vert that's in front of it, and the accessory nerve is just behind it if you're looking for it. Dorsal rootlets of C2 are seen at the arrow. Sometimes you can have a ganglion associated with the C1 dorsal rootlets at that arrow, and you can see that it's usually intradural. If you see it when you're doing a posterior fossa or high cervical approach, it's not something that's pathologic. It's just a normal ganglia that we see from time to time. Some other high-priced real estate in the area. This dissection, again, not being compatible with life, but shows some of the niceties in this area. For example, the horizontal segment or that V3 segment of the vert and its relationship to C1 and the AO joint. I'll leave these with lack of time so you can look at, but each little joint has a discrete amount of freedom that it can move. A lot of this freedom is translational movement, and in teaching and looking at the biomechanics, you can think about the occipital condyles being analogous to an egg and a spoon, right? With the spoon being the superior articular facet. And if you keep that in your head, that's basically what that joint can do. With those strong capsular joints, remember they had about 300 newtons before they would rupture, which is strong. You don't get a lot of movement. It takes that collective movement at each of these joints before you get to do something like that, which is lateral flexion. But taken individually, they don't have as much meaning. In kind of closing, lots of morphometrics of C1 and C2, and you can draw tons of lines. Some of these are clinically useful, some are not. This probably is a good take-home picture of some of the things that have been used in the past to discern whether or not the bony parts are in their appropriate location. Wackenheim's line, I think, is pretty useful, or that Clival line. You need to always make sure that your predental space is what it's supposed to be, right? 3 millimeters in adults. It can be up to 6 millimeters in kids, and after 6 millimeters, supposedly transverse ligament has to be avulsed. Powers ratio has some utility as far as if you're trying to figure out whether there's any anterior subluxation. Thank you.